from medical team of Zydus. We would like to thank MSG for letting us collaborate for today's meeting. With this, I'll like to hand over the session to Dr. Amit, sir. Over to you, sir.
Thank you, Dr. Shivash.
Very good.
So, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Naval Davar from MD Anderson Cancer Center, Houston, Texas, USA. And he's going to lecture us on acute myeloblastic leukemia, integrating MRD in clinical decision making relation to allo stem cell transplant and maintenance decisions. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Naval Davar from MD Anderson Cancer Center, Houston, Texas, USA. All our discussions were themselves very eminent hematologists and medical oncologists, and you participants for sparing the Saturday evening, morning and afternoon. Tomorrow, that is 4th of February 2024 Sunday, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on sound bites from ASH 2023 by our guest speaker, Dr. Vishal Jaikar from King's College London and Kingston Hospital, Imperial College London. Now it's a time to introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Alka Khadwal from PGI Chandigarh, Dr. Anil Singh Airom from Jawaharlal Nehru Institute of Medical Sciences, Imphal, Dr. Aryan Jain from PGI Chandigarh, Colonel Dr. Ashok Meshram from Command Hospital, Kolkata, Dr. Bilal Qazi from Apollo Multispeciality Hospital, Kolkata, Dr. Kunal Goyal from ACTRAC, Mumbai, Dr. Mohammad Mir Hussain from SKIMS, Srinagar, Dr. Mopali Ghosh from Institute of Hematology and Transfusion Medicine, Kolkata, Dr. Niranjan Khair from PGI Chandigarh, Dr. Rajat Pincha from Tata Medical Center, Kolkata, Dr. Riyashma Roshan from Sher-I Kashmir Institute of Medical Sciences, SKIMS, Srinagar, Jammu and Kashmir, Dr. Rupam Deka from All India Institute of Medical Sciences, Guwahati, Dr. Sanjeev Digra from Government Medical College, Jammu, Dr. Shilpa Bhartiya from Apollo Clinicals Hospital, Kolkata, Dr. Siddhartha Sankar Ray from Medical College, Kolkata, Dr. Soumya Mukherjee from Apollo Clinicals Hospitals, Kolkata. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Naval Davar from MD Anderson Cancer Center, Houston, Texas, USA. Dr. Naval Davar is a professor and director of the Leukemia Research Alliance Program in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. He is a clinical investigator with a focus on molecular and immune therapies in acute myeloid leukemia and myeloid disease, and is principal investigator on more than 25 ongoing clinical trials in these diseases, including multiple potential national and international registration studies and label enabling trials. These trials focus on developing a personalized therapy approach by targeting specific mutations or immune pathways expressed by patients with AML, evaluating novel and rational combinations of targeted immune and cytotoxic agents, and identifying and overcoming mechanism of resistance. He is especially interested in developing FLT3 inhibitor-based combinations, monoclonal antibodies, immune checkpoints, CD47, NK and T cellular therapy approaches, as well as combinations of targeted and apoptotic therapies in AML, and is leading a number of these trials. He has published over 450 peer-reviewed PubMed index manuscripts and is on the editor board of hematology journals. He also serves as chair on numerous international leukemia meetings and educational platforms. And today he's with us and is going to lecture us on acute myeloblastic leukemia, integrating MRD in clinical decision making relation to allo stem cell transplant and maintenance decisions. Well, thank you so much. Over to you, Dr. Naval Davar.
Thank you very much, Dr. Khurana. Pleasure to be with you all, and looking forward to the discussion. It was good to see many of you in India very recently as well when I was there. last month. So I'm going to be talking about some of the updates from ASH and also on MRD, where things are. Let me put this in slideshow. Okay, do you see it full screen now?
Yes.
Okay, great. Yeah, so I'm going to kind of talk about some of the molecular updates, some interesting things that came in ASH, and then try to focus a lot on molecular, which actually works well because a lot of the things that came out at ASH actually for the first time were focused on molecular data and how to integrate molecular MRD, especially for FLT3 and NPM1 in the treatment of AML. And we had a similar discussion. I gave a similar talk to our group at MD Anderson actually just a few days ago, which led to a lot of interesting discussion and still many, many, many questions to be answered. But I think everybody truly agrees now that MRD is here to stay. It may not be for all AML. We still don't know exactly the modality, but at least for some subsets like NPM1, FLT3, maybe MLL, the data is becoming stronger and stronger that you can use molecular MRD and you may be able to get very high sensitivity similar to clonoSEQ in ALL. So I think this is now the last couple of years where MRD has come to the forefront. But before we jump into that, I think it's always good to start with a introduction for maybe some of the fellows or junior members who are not as immersed in AML as some of you may be. So this is the molecular landscape in AML. This shows that it is a very heterogeneous disease. And this really does also impact how the difficulties of MRD management in AML have been compared to those in more homogeneous diseases like acute lymphoid leukemia, for example. So you see here, most AMLs may have multiple mutations. There are different mutations. These include signaling mutations like FLT3 and RAS, Sybil, KIT, as well as epigenetic mutations, DNMT3A, ASXL1, EZH2, RUNX1, as well as, of course, TP53, and not just mutations, there are also fusions and rearrangements. And I will tell you the number of those that we are starting to identify as we get more advanced techniques, such as optical genome mapping for cytogenetics or RNA translocation panels, has increased quite a bit. So I think that it's not just molecular architecture that in the next 4 to 5 years will be focused on, but we're also going to be looking again at kind of fusion partners and cytogenetic rearrangements in a different light with more advanced techniques. And this may be important in light of new treatments that are coming, such as the menin inhibitors and others that depend heavily on fusion upregulation of certain pathways like MEIS1, HOXA. So a lot of new developments, but molecular is kind of what is more standardized, commercially available, widely used across the world today. And just to show, this is one of many, many, many such slides and publications coming from different cooperative groups and different centers, just showing that you can use even the current available information to really at least risk stratify and prognosticate AML quite differentially. So you can see here the prognosis can be anywhere from 85% to below 20% for 4-year survival, depending on the underlying cytogenetic molecular profile. And this is the reality. You see patients in clinic. I just had one 2 days ago, and they come with a new diagnosis of AML, and they ask, doctor, what is the outcome? And I always tell them, I really have no idea until I get this information. That patient turned out to be a core binding factor, which puts them on this curve here close to 80% potentially. In fact, this is older today in our population. We're getting close to 80 to 83% survival. Same patient, if they were TP53, complex karyotype, would be a very different story, and the curve could be very low. So I think it's really important that we don't think of AML as just one entity. It really is a conglomeration of multiple different molecular cytogenetic groups, which have extremely different prognosis. And not just prognosis, this also impacts now significantly our treatment. So this is kind of the current list of potential targeted therapies, and this will continue to grow. Many new targeted agents are coming in the pipelines for other aberrations, such as the MECOM rearrangements, etc. But today we have FLT3 mutations and inhibitors. Now 4 of them are commercially available. 3 of them are fully FDA and EMA and approved in India. So these include midostaurin, sorafenib, gilteritinib, and quizartinib hopefully will be coming to many countries in the near future. It was just approved in the US a few months ago. IDH inhibitors currently are approved in a few countries. They have not had global approval, but these are very good drugs. And I hope eventually there will be a way for them to be available. And then menin inhibitors, I think, are the new important target therapies. There are actually 5 of these already showing the degree of excitement from the pharmaceutical arena, because they see that this could be a very promising treatment. And we also see that in our experience. So Syndax, Cura, J&J, Sumitomo, Biomea, all of these now in different clinical trials. These target the aberration called the MLL rearrangement or the NPM1 mutations, but not just those. In fact, they probably target other rearrangements such as the NUP translocations, the UBTD, as well as potentially 821 and others. So we're waiting to see, based on RNA sequencing that is ongoing in our institution, the full profile of where these drugs could be used. And I think it may end up closer to about 25 to 30% of AML that may have MEIS1 HOX-A upregulation that could benefit from menin inhibitors. For the others, TP53 and RAS, these are probably our two biggest unmet needs. There's a lot of research, especially in line with immunotherapy ongoing for TP53. At this time, none of those have led to breakthroughs, but I do think it's a matter of time with the amount of analysis, research, and trials that are coming, especially cell therapies, which I think you will see a lot in the next couple of years in AML. I think one of these or many of these hopefully will at least be able to move the needle in TP53. I think cure is going to take longer, but hopefully we can at least get deeper remissions and consolidate with transplant and improve survival for some of these patients. And then RAS inhibitors are also being looked at. So it's really important to know the molecular architecture, not just for the prognosis, as I showed you on this slide, but also to select the right treatment, whether it is in frontline or salvage. Now, FLT3, I think, is a really good poster child, an important one to discuss because, FLT3, the outcomes have changed quite dramatically over the last 20 years. This is a slide I always like to show because it kind of gives you a historical check. And this is not ancient history. This is only about 20 years ago. But you can see that the expected median survival, the 4-year survival for the FLT3 mutated in just 2002 was about 20%. And now I will show you the data where this has improved quite a bit with the use of FLT3 inhibitors, transplant, and maybe even further with post-transplant maintenance, where we today are expecting and publishing close to 70-75% potential 4-year survival for young patients below 60 with FLT3 mutation, improving on this historical 20-25%. I think one of the things that has really revolutionized the treatment of FLT3 inhibitors, probably the most impact, has been the use of FLT3 inhibitors. There are many different FLT3 inhibitors. These are called type 1 and type 2 FLT3 inhibitors. It doesn't really matter the type 1 or type 2 so much, but what matters is what they target. So many of these, such as midostaurin, gilteritinib, they target both the ITD and the TKD formation. So they can target pretty much all of the FLT3. On the other hand, those that are type 2 alone only target the ITD. So we can see after treatment with those drugs like quizartinib, you may have escape through on-target TKD FLT3 mutations, and then you could switch to a gilteritinib-based regimen, and that should actually still have activity. Now, that does not mean that a lot of people say, oh, so the type 1 inhibitors are better. Not really. They just have different mechanisms of escape. So although they can cover ITD and TKD, we see that the majority of escape happens in mutations in other pro-survival pathways, such as RAS-MAP kinase or the BCR-ABL, and so the leukemia still finds a way to escape. So I don't think that these compete with each other. These are probably drugs that can be used sequentially, overcoming resistance patterns to each other, and ideally in combinations, which will further suppress or mitigate the ability of resistant clones to emerge. And in the end, just like with CML, where there are already 6 TKIs actually, and 2 more potentially that are looking for approval, there will be use of these based on the patient's underlying comorbidities, age, the combination that is being considered, and other factors. So looking at all of the progress now in FLT3, if we try to combine the key things that have happened in the last 15 years, there have now been 7 actually randomized studies. All of these have actually shown improvement in survival, whether these are frontline, adding a FLT3 inhibitor like quizartinib or midostaurin to intensive chemo, whether these are maintenance studies. 2 of them were with sorafenib, 2 randomized phase 2 studies, and then more recently, the randomized gilteritinib morpho phase 3 study. I don't have that here, but we'll discuss that more later. Or in the relapse setting, where single-agent FLT3 inhibitor was at least better for response and survival than intensive chemo, but also shows that there is still a lot much to be done. It is better, that's true, and it met regulatory approval. However, when you look at the 1 and 2 year survival, we are still in the 20-25% range. So I think it's a good analysis to get the drugs approved, show show it is better than intensive chemo, which is really good. An oral single agent being better than 3 or 4 drug IV chemo, like a FLAG-IDA MEC, is very impressive, but also showing that single agent targeted therapy is unlikely to cure the bulk of patients. And if we want cure, either they have to be moved upfront or they have to be developed in combinations if they're used in salvage. So in that line, we at MD Anderson have always been very much on the combination track from the days of Emil Freireich in 1960s, who was one of the fathers of oncology actually in America, not just leukemia, who first pioneered combination treatments for many different cancers, along with Emil Frey when they were at the NIH and then at MD Anderson, in fact, leading to some of the first combinations in childhood ALL and in breast cancer. But since then, we have always believed that combination approaches, whether they have unique synergies or even independently have activity that cannot be generated by giving drugs sequentially. So you know of the story in ALL where we have been combining hypercVAD with ENO, with blina, or with ponatinib, and shown that that dramatically improves your depth of response and survival. Of course, there's always a myelosuppression factor that comes in, and that's why combinations always have to be adjusted. You never give full doses of the components. You adjust down to allow for the buffer that will happen with myelosuppression. So we have moved on to a CLIA sorafenib. I think cladribine is a very, very interesting drug, kind of now making a resurgence. So we have always found this to be an effective drug and have been using the regimen of CLIA now for almost 7-8 years. Dr. Kadia and our group has been championing this effort. And you can see here, even with CLIA and sorafenib, so this is not even a second generation FLT3 inhibitor like gilteritinib, quizartinib, just with sorafenib and CLIA, here in our experience with 55 patients treated at MD Anderson. These were all longitudinally treated patients. We treat 90 to 92% of our frontline patients on trial, so there's not really much selection. If they're not in the ICU or extremely sick, they pretty much go on the trial. And here you can see that the 3-year and 4-year survival is above 70%. So this really is our expectation, and this is already based on sorafenib. We definitely hope that now that we've moved to gilteritinib with CLIA, this will be further improved. And cladribine is not just something that we're excited about. This is something that, in fact, the Polish and the British for more than a decade have been looking at. In fact, the Polish have even had a randomized phase 3 study, 700 patients, of cladribine added to daunorubicin cytarabine versus daunorubicin cytarabine, and showed that both the ECR, EFS, and OS were improved with the cladribine-containing arm. This was published in JCO by Holowicki et al. But what they further found that especially in the subset of FLT3, and preclinically this was also shown, the addition of cladribine to the backbone of anthracycline cytarabine seems to have a benefit. And now recent data from Dan Polier, Craig Jordan, and the group at Colorado coming out very beautiful preclinical data suggesting that cladribine, among all the drugs they tested, 20 drugs, has a very specific activity against monocytes and monoblasts. So we didn't really know that at the time, but there was always something we felt unique and special about cladribine. And I think now more and more it is coming back in the forefront, and many cooperative groups in Europe, as well as many big centers in the US, are moving towards this. And I think for FLT3, I would personally consider such a regimen, anthracycline cytarabine with cladribine, with the addition of FLT3 inhibitor, transplant. I think especially for young patients below 50, 55 who are fit, this could be a highly curative regimen. We hope to update our gilteritinib CLIA also potentially sometime later this year, and it is also looking good, although the follow-up is shorter there, so we will have to continue that for a little while. Now, meanwhile, of course, there has been more progress beyond even sorafenib, gilteritinib, the frontline space, with the recent approval based on this randomized phase 3 study called the Quantum First study. This is Quantum First. There's another study called Quantum R, which stands for relapse. The Quantum First study is of more interest, I think, to me and many of us. This looked at quizartinib compared to placebo, added to anthracycline cytarabine backbone. It's a global study, about 140 sites across the world, and there were sites in Asia, Europe, North America. And these were patients who had FLT3 ITD only. So that's important to remember. This drug only works for ITD. It does not have TKD activity. The second thing is this trial allowed patients in a broad age range, 18 to 75. The prior study of ratify midostaurin only was 18 to 60. So this is older population. 40% of the patients on this study were above 60 years of age. Those 40% patients would not have come on ratify. So this is a more difficult population. all ITD, which tend to do a little bit worse than the ITD and TKD mix that enrolled in Ratify, and all ages, not just cut off at 60. That being said, the study met its primary endpoint, which is good, but I think also really shows that we still need to do a lot of work. So although in academic centers and potentially with the use of cladribine and better management, we may be able to get to 70% or so long-term survival. When you go to a global study, and especially if you start treating patients above 60, that survival is probably closer to about 50% or so, not 70%. Now, that being said, the details are really quite important. And I think this slide, which I made, is very important because you have to really try to compare these trials in the same light. A lot of people in the US call me, and in a lot of the meetings and talks, I go say, well, why are you excited about quizartinib? It looks like the same to me when you put the curves next to each other. But you can't really do that when 40% of the patients are above 60 on the quizartinib study, and these were not included on midostaurin. You already have a completely different patient age profile, which we know is very, very important in AML outcomes. So to try to look at this, we actually worked with the Daiichi team, and I pushed them to show the outcome, although this was not a pre-specified statistical analysis. But in the end of the day, we have to use the data because it's very unlikely there is going to be a big randomized study of quizartinib versus midostaurin. So what do we do to make decisions today? And so they were able to do this analysis, and I think this analysis was very helpful. So now when you try to look at a similar age population, so those who were below 60, which was the entire Ratify study, and those who were below 60 with quizartinib, which is 60% of that study, you see now the 4-year survival rates are different. You have 50 versus 60%, and also getting closer to what we would have expected and what we are showing from other academic centers, where 4-year survival in young patients, which really is below 60 today, in the US with the emergence of HMA-VEN, and fit patients with intensive chemotherapy, you can, in fact, in even a global international study, start talking about 60%. That's impressive because, as I showed you in the first slide, this was exactly 20% 20 years ago. Today, in a large randomized multinational study, this is up to 60%. I personally feel with the maintenance and potentially with improvements such as incorporation of cladribine, as we are seeing, it is possible to pull this above 70%. But it also shows that in older patients, we need to reconsider what we're doing. Even in a randomized study, which had inclusion-exclusion criteria, and was done in academic centers, you're still seeing that the long-term survival is poor, only 14-month median survival. And when you look at the early mortality in the first 3 months, there's still a 20% drop-off. So it really gets to the point that intensive chemotherapy in older patients, even in the contemporary 2015 to 2020 timeframe, when this study was done, is not much better than it was, and it's still quite toxic. And that, of course, brings up the question, now that we have a good alternative, why should we push our patients above 60, 65 on intensive chemo? So this is kind of the approach we started taking already a few years ago. As you're all very familiar, we've published on the so-called triplet regimens with FLT3, with IDH, now with menin. And again, these are not randomized studies, and I think it will take years, and you cannot do every randomized study on earth. That's the reality. You know that from myeloma. So we're going to have to make best clinical decisions based on best available data. So here I show you some of the seminal studies, the CLIA-sorafenib that I mentioned, which is kind of our most recent mature study of intensive chemo with the addition of cladribine and a FLT3 inhibitor, which shows 70% long-term survival. The gilteritinib, which is still early, but is looking similar at about 70% or so survival. And then the quantum first, which, as I mentioned, even for the entire population, but especially for older populations, is showing the median survival of only 14 months. That's the bottom curve there. And then you look at the aza-ven gilteritinib. This was just published in JCO 4 days ago. Dr. Short is the first author. I'm the second author. Dr. Avandi, the last with us. So we've been working on this for a long time, and you can clearly see this looks promising. And this is not a practice-changing slide, but this is a food for thought. I think we are at a point where we have therapies such as aza-ven gilt that can actually compete and may actually be better options even for certain younger patients between 50 and 60, 60 and 65, 60 and 70, who intensive chemo you may be worried about. You may think I could push him through it, but the mortality is high. You may think that this patient could tolerate it, but the ICU rate is high. I personally, when we see these patients, we are now moving more comfortably to HMA-VEN FLT3 inhibitor. And over time, I think this may start moving down the age group to a younger and younger population. So I think the actual backbone of treatments and approach to AML is kind of in a flux period. So now a little bit about MRD, which links a lot to kind of these discussions because MRD is very dependent on what treatment you're using per se. And here you see the different technologies of MRD. You have flow cytometry, you have molecular RT-PCR, you have NGS-based approaches. I'm not going to go into a huge technological discussion of how these are done and the pros and cons of those. But I think what is very clear, and one can go through hundreds of papers, but just to highlight some of the key ones, to make the point, MRD has clear prognostic value, whether you use it by flow, as was done by Sylvia Freeman and the British group. They have been some of the champions in MRD, and along with us at MD Anderson, as well as the Hovan group, publishing that flow MRD is very predictive and adds value beyond response. So just a CR/CRI, if you see the outcome, it could be quite good, 63% compared to 44% when you add MRD data. So MRD does add differentiation beyond just the CR value, and this is true in many different subsets and populations that were treated. Others ask, well, what about HMA? We use so much HMA treatment. Is it the same? Does MRD still have prognostic value? So our group with Dr. Vandi looked at this, and in fact, what we see is that yes, there is a difference. As you can see, the cumulative incidence of relapse, at least, is predicted by MRD, and you can see the relapse rates are significantly higher, 60 to 80% compared to 40% in those who achieved MRD negative versus positive, although this is heavily all based on flow cytometry. And interestingly, survival was not that different, but you see the numbers are small. So that could have been one of the factors. The other factor could be the survival with HMA alone is just quite poor in general in older AML. So you may not have enough of a delta because there are very few patients who have long-term survival. Now, as you get into MRD, it gets tricky in AML. It's not like ALL, where yes, flow is good, clonal is good, positive is positive, negative is negative. In AML, positive is not always positive. There are certain mutations for which the MRD clinical impact and value is not clear. And these include the mutations that we call the CHIP family mutations. CHIP is clonal hematopoiesis of indeterminate prognosis, or patients who have certain mutations that we don't know if these are directly linked to the eventual leukemic transformation or were pre-existing mutations that have been there for years and may stay for years and may or may not be good trackable mutations. So the Hovan group and the Spanish group looked at this, and what they found is that there is a group of mutations called the DTA, DNMT3A, TET2, ASXL1, and that if you look at these mutations, persistence of those mutations was not associated with a survival, and they're not good for MRD. But when you exclude those mutations, it is very clear that the molecular mutation analysis can be used successfully for MRD assessment and did clearly predict, on top of the existing factors, for overall survival prognostication. And this is what they showed here. What they also showed was that if you can do more than one MRD technology, it's going to be better. Now, this is intuitive, of course. The better coverage you have, if you use NGS and flow cytometry, you're likely to have a better prognostication. And then it's intuitive, but it always has to be shown. And they did, and they showed that basically, when you look at the incidence of relapse, those who are NGS molecular positive and flow positive, basically these patients, you can call the blast whatever you want, 4%, 3%, it doesn't matter. These patients have pretty much equivalent to relapse disease. Their relapse is going to be 75%. On the other hand, you have those then who are both negative, and these patients actually have a deep response, and you can see at 5 years, they have a 25% or less chance. So this is kind of the approach that is being used now more and more. And you do see there's a lot of concordance. 70% of those who are NGS negative were flow negative. That is good. But there is additional value if one can do both, which is currently the approach we are taking at MD Anderson. Then probably the biggest meta-analysis, and I would recommend very strongly for those of you, whether you're students or fellows or treating practitioners, to read this, because this is probably the one paper on MRD, if one wanted to read one, that covers all of the historic data as well as has put together 9,000 plus patients, very well written. It's in the JAMA, very high impact, and really kind of establish a baseline for MRD. This was heavily based on flow, And this was really done also for the US FDA to be able to use this in the future for MRD-based intervention strategies, but clearly shows that MRD positive have a poor outcome, 5-year survival of 30 to 40%. MRD negative, on the other hand, can have a very good outcome, close to 70%. Really also gets to the point of how one should think about AML. I still think there's a nihilism in AML. Even we see this in our ICU and EC. It's getting better, yes, but people have this impression that, oh, it's acute leukemia, this person not going to make it. Actually, this is not true. If you can achieve a good remission MRD negative with current tools like FLT3 inhibitors, venetoclax, cladribine intensive chemo, we can, in 80%, this could put a lot of those patients on a 70% 5-year survival. I would challenge people to find many solid tumors that can show a survival curve like this, even with the use of MRD, except for melanoma. This is tough. So I think AML is in a phase moving towards outcomes in acute lymphoblastic leukemia and others, but we still need to identify those who need less treatment and can be cured quickly, like MRD negative, and then those who need more treatment and what to do for them, like the MRD positive, immunotherapies, transplant, other approaches. And that is something that is still being worked on. I wanted to show this British MRC study. I thought this was a very interesting study. So as I mentioned, the Polish did something like this quite a few years ago, looking at DA versus DA cladribine, and basically showed and published in the JCO that DA cladribine was superior when it came to CR, event-free, and overall survival, all parameters, and met the endpoint of that large phase 3 study. The British then kind of took that and said, well, let us try to look at that and confirm that. But instead of using it up front, what they did is they gave everybody up front either DA or DA with gemtuzumab 1 dose or 2 doses. That's the DA-GO1 and 2. But then this is probably the first planned MRD-based early intervention, I guess is how I would call it. They actually did MRD on all patients, close to all patients, and then they decided based on MRD positive versus negative if the patient should go onto a intensification cycle versus those who are MRD negative. Let's not push for those patients, continue the DA1 consolidation, and then IDAC as the third consolidation, and then we're pretty much done. Transplant decisions was made by individual investigators based on baseline factors. And then for those who are MRD positive, then you go for a more intensive approach where you see whether the addition of fludarabine or cladribine could improve that MRD positive high risk group. And so this was all done based on flow-based MRD assessment. And as you can see, majority of the patients did have analysis that was available at that time. I think it's here, next slide. Yeah, so here you see that of the 1,100 patients who were post-cycle 1 of DA or DA plus GO, that doesn't matter. They were post-cycle 1, and then 523 were entered into randomization. This included about half the patients who were MRD positive, 259, and then there were others who were either not in CR/CRI1 or were CR/CRI1 MRD unknown. So all these patients were considered as high-risk group, patients who needed to get maybe something beyond DA. That was the question. So these 523, no CR/CRI, MRD positive, MRD unknown, were then randomized into those 3 arms: DA, which was what they had been using in the past as consolidation regardless of MRD, or addition of fludarabine or cladribine, the intensive course, to see if that did something better than DA. The other 500 were MRD negative and then moved on to the appropriate therapies. So that was kind of the plan. So this is kind of just looking at count recovery, because the big concern or anxiety that we have seen in the US is that, oh, if you add cladribine, fludarabine, it's going to make my count recovery so difficult and my patient have myelosuppression and die. And this is to some extent true, that there's a little bit of added myelosuppression, but it's not severe. When you look at the ANC recovery above 1, you're talking about 25 to 29 days. When you talk about platelet recovery, this is 26 to 33 days. So of course, these are medians and there are always individuals, and one has to be smart when you select it. Would I give this to a 65, 66-year-old? Probably not. Would I give this to a 40-year-old? Probably yes, because that 5 to 6 day is manageable. Those patients are young and healthy. You can give them antibiotics, manage it. But of course, the outcome could be improved. I think what was really nice to see is this. So early mortality, and I have to say I was a bit surprised by this. in a large, again, this is not one center, this is about 20 centers in the UK who treat about 80% of all of their AML. So this is basically UK AML practice standard, not a select group of centers. And what you see is that the 30-day and 60-day mortality was the same with the cladribine and the DA. So no addition of mortality. Interestingly, the fludarabine, there seemed to be a slight increase in mortality. This is not something we have seen, but this was their experience. So we have to look into that more over time, why that was the case. And then when you look at overall survival by randomization, there was no significant difference, whether you look at the DA versus FLAG-IDA or the DA versus the DAC, although one can see there's a trend starting to come between the DAC and the DA. But still, I think too early to say that there's been a big difference using this MRD intervention at this time point. I think what was really interesting was those who had confirmed MRD disease, because remember it was a pool of patients, no CR, CRI, MRD unknown. And then there was this group, just to show you here, who was this population, the real population of interest, 259 in CR, CRI, MRD positive. So those are the ones you really want to know, because that's the objective pattern. So now it's interesting, if you knew that that person was in the CR, CRI and was MRD detected positive, here you start seeing both the addition of fludarabine or cladribine is improving your overall survival for those patients significantly. So now it does suggest that the addition of the more intensive backbone can have a benefit. When you look at MRD conversion in those who, of course, had a clear documented MRD positive, excluding the MRD unknowns and those without CR, CRI, you can start seeing also that there are higher conversion rates with the DAC and the FLAG-IDA, which again are statistically significant, 51 versus 63 and 58. And then when you start looking at the approach of intensification, what impact it has, not just on survival, but also in relapse risk, this starts to get more and more clear as well, 70 versus 58, 60% at 4-year relapse risk with the use of the more intensified purine analog containing backbone. Now, transplant is interesting. They actually did have a number of patients who went to allogenic transplant, about 36% of the patients. And when you split it, this was kind of even between the 3 different groups. And that was not by design. That just happened because it was a randomized study and they saw there were similar transplant rates across the 3 groups. And the majority of these transplant happened somewhere around end of cycle 3. So what they overall saw was that when you look at patients who are, again, definite MRD positive, excluding the unknowns and the non-CR, CRI, even after censoring for transplant, and here you see very interesting, there is a benefit, but only with the cladribine arm, not with the fludarabine arm. So there again seems to be something unique that the British, like the Polish and like us and others are finding is happening with cladribine. Maybe it's the monocyte story that Craig Jordan and the University of Colorado group are looking at and publishing. Maybe there's something else. But basically what they said was, overall, when you look at these patients with confirmed MRD positive who are in other CR, CRI, using an intensified regimen, adding a purine analog to the anthracycline cytarabine, first time in a randomized study showing an MRD intervention led to a 5-year survival benefit, led to improved MRD clearance, reduced relapse risk, and most importantly, did not increase the 60-day mortality, especially for the DAC. And the DAC, they actually did say clearly seem to be better tolerated. And unlike FLAG-IDA here, they say the DAC intensification led to a long-term survival benefit, even in non-transplant patients. You know, we cannot predict who's going to get transplant or not, but the DAC given in the MRD positive setting will still be able to give you that benefit. So this, I think, is quite interesting. You know, we think really is, again, a third evidence supporting cladribine use here in the appropriate setting for young patients. And it could be done upfront as we do right away, or it could be MRD gated. Now moving towards a FLT3 inhibitors and MRD, there was actually a couple of data sets here that I thought that were quite interesting that we can look at. So this was one from the Quantum First with my friend and colleague, Dr. Sasha Pearl, who presented it. I thought this was very, very nice data. So Quantum First, just to remind you, was the quizartinib versus placebo added to the backbone of 3+7 anthracycline cytarabine. Primary endpoint survival met. Drug was approved by US FDA. Hopefully will be approved by EMA and Asia and India in the near future. So that's the backbone. But really the question was, does MRD monitoring have a benefit or impact, or why is quizartinib working better? Is it because it gives you a deeper response, or is it because of some form of continuous long-term kinase inhibition? And so this is what they wanted to look at. They had MRD prospectively checked at least 3 time points, a CR time point, consolidation to an end of consolidation. This was done across all of the centers. Really commendable that they were able to get MRD collection in almost 80% of the patient at all of these time points. And then they use 2 cutoffs. So this is where it can be a little bit confusing, but they use a 10 raised to minus 4 cutoff. And this is a predefined cutoff because this is what the US FDA accepts as an MRD level and what most labs are able to get at a quantifiable level. But then there was also a true zero, which for this assay goes all the way down to 10 raised to minus 6, although it cannot be quantified at that level, but it can give you a positive negative readout. So that was kind of the approach. Again, here just to show this was not flow. This was using a technique called a PCR NGS, where basically the first step is to do a PCR amplification, and then you do multiple amplifications, and then the NGS is read on the final amplicon product. So it actually uses both PCR NGS technology, and you can then go down to 10 raised to minus 6 as a lower level of detection, LLOD. However, the lower level of quantification accepted at this time by the US FDA and the CLIAs are 10 raised to minus 5. But to me, really, basically, you can get to 10 raised to minus 6 is the way scientifically I think about it. What they showed again was very interesting and intuitive, but also important to show, was that MRD did predict for survival. Whether you are on the quizartinib or the placebo, doesn't matter. Here they're just saying, if you achieve MRD negative, you do better than those who achieve MRD positive. What they also showed, which is quite interesting, is that the 10 raised to minus 4 may actually give you good prognostic differentiation. There's maybe a little bit better with the 10 raised to minus 6 at 0, but not too much. So really, if you're getting a deep remission below 10 raised to minus 4 level, or close to 10 raised to minus 4 level, you're probably doing well. Deeper may be better, but may not be absolutely required. And one should not feel bad if you have this technology and you have a 10 raised to minus 5.0001 detectable. It's not a reason to jump on changing treatments or do anything. If you're 10 raised to minus 4 or lower, you're probably going to have a good outcome and you can monitor those patients. Now, this is looking at where does quizartinib fit into this. And it was pretty clear when they showed this that when you look at the MRD negative, and here they're looking at the 10 raised to minus 4 and the 0 cutoff, but when you look at the 0 cutoff values, you see that in each case, quizartinib was showing much higher MRD negative conversions than placebo-intensive chemotherapy. So quite big differences, and maintain at the end of consolidation at 56 versus 41%. So that's good. We expected and hope to see that. And then what they showed is that if you become MRD negative, whether you're on the placebo quizartinib arm, your eventual overall survival is good. But of course, more people became MRD on the quizartinib arm. So although yes, MRD negative is good, you have a better chance of getting there with the addition of the potent FLT3 TKI. That is fine, and again, makes sense. So you want to use quizartinib, you want to get more patients MRD negative, and then your survival curve will look good. There are more people on the quizartinib curve here than there are on the placebo curve. So that's good. But what about those who don't become MRD negative, regardless of what they got? We cannot predict that they will become MRD negative, whether they get quiz or placebo. And that was interesting, that even if you did not become MRD negative, there still seemed to be some benefit. This may be signaling inhibition, long-term suppression of FLT3, we don't know, but there was some benefit of quizartinib still being maintained. So really, to me, it suggests you want to start the FLT3 inhibitor early. The benefit in the early first 2 to 3 months comes from higher MRD negative conversions. That will get your patients, more patients onto this curve than in the placebo curve. As you can see, there are more patients on the curve on the quizartinib, 88 versus 66, 48 versus 35. But you want to then continue the FLT3 inhibitor because there may be some long-term benefits seen. And especially if your patient has an MRD positive low, or maybe the MRD is popping up and down, you may not be checking, then it's safer to continue the FLT3 inhibitor. And that's our practice today. We are continuing FLT3 inhibitors, knowing that we will have a better chance of MRD negativity. And even if not, then we will still have a benefit for the MRD positive. They then looked at some other things, basically showing that those who had more than one FLT3 ITD mutation tended to have a higher risk of relapse, worse outcome. Kind of makes intuitive sense, but also interestingly, that quizartinib continued to do better in those patients, whether they had one or more FLT3 ITD mutations. I don't think this changes practice much. Use the FLT3 inhibitor if you see a FLT3 mutation. Bottom line, one or more doesn't really change my practice today. We're trying to take all these patients transplant, so that's what we're doing. Now, in the future, if we get to a point where MRD technology becomes good and we have good maintenance, survival curves are starting to look as good without transplant, then maybe this one versus multiple mutations could be something that comes into play. Then the other paper that I'll cover and probably stop after that, just in the interest of time, is this Morpho study. Now, this I think could have a lot of this could have practice implications in India, depending on how you choose to use those. But I think the cladribine data is interesting, especially in the MRD setting. I think FLT3 inhibitor, using it early, using MRD monitoring and continuing is interesting. But I think this one probably has the most clear impact in 2024 that one could use. So this is the Morpho study. I'll tell you what the Morpho study is for some of you who didn't know, but this is the first randomized maintenance study post-transplant with any drug, but here it was with a targeted therapy. It's really difficult to do post-transplant randomized studies across many countries and 100 centers, and the BMT-CTN and Mark Levis, Charlie Craddock, and many colleagues, Yibin Chen, did a great effort to get this study moving. And the data are quite interesting. I will tell you, it's going to be published probably in the next couple of weeks in JCO, and there's an editorial by Dr. Charlie Craddock and me on this, so look out for that, and hopefully you find that informative, because there are details in publication that have not been shown yet in any of the presentations. So this is the approach of the study. So they said any patient who's FLT3 mutated, who is going to transplant, the normal practice in 2015 or 14 when the study started was you do the transplant, you do maintenance, immunosuppressions and things, but you don't do any further therapy. That was a standard practice. Transplant was the end of the line for the train, and then you just hope the patients were cured. 50, 60% were cured, 40, 50 weren't. Okay, too bad. That's what we have. Then they said, why? Now you have these great drugs. We're using them with intensive chemo, you're using them with HMA, you're using them in salvage. Why should we not use them post-transplant? Myeloma continues treatment post-transplant. The total therapy approach, Barlogi and others pioneered, you continue to suppress the clones and you improve the outcome. So then this study was designed, and this basically said, okay, once you have that patient who's FLT3 mutated, they were only ITD, that's important. This study only had FLT3 ITD mutated. They went to transplant, then we're going to randomize them post-transplant. You either get gilteritinib or you get placebo, which would be the standard, meaning you're not doing anything. Everything else you could do per national or institutional practice. That may have been not ideal in the study and may have caused some problems, because we ended up with 8 or 9 different conditioning regimens, and we ended up with very diverse use of antifungals, and I think that muddied the outcomes a little bit, but that was the only way it could have been done, because, as you know, transplanters are very attached to their approaches, even more than leukemia doctors, I think, and otherwise the study wouldn't have happened. So that's how the study was done. And the key issue here was that the MRD was monitored, and look at this, at 98%. This is amazing to have MRD monitoring done in 350 of 356 patients. And again, shows you that in the last 5 years, all of these big studies are including MRD. And I think this is finally what will tip the balance for the FDA and regulators to start saying, okay, now we have all of this bulk of data from randomized studies showing how MRD is important, how it can prognosticate impact, how interventions can be done on it. It can become an endpoint. I think that is coming very soon in the next few years, like it has for ALL and myeloma. And this study, they used, again, this same 10 raised to minus 6 assay, and they only called MRD that was 10 raised to minus 4, minus 5, minus 6. They said anything more than 10 raised to minus 4 should not be called MRD. That is basically active bulk disease. So this was true MRD, where you're saying 0.01 or lower is only what should be considered MRD. They checked MRD right before transplant and then right after transplant. And anybody who had an MRD positive right before transplant, right after transplant, what we call peri-transplant MRD positive, was considered to be the MRD positive cohort, which was half of the patients. So 50.5% had MRD positive right before or right after transplant using this high sensitivity FLT3 PCR. It could have been MRD 10 raised to minus 4, 10 raised to minus 5, 10 raised to minus 6, detectable. Anything higher than 10 raised to minus 4 was not counted as MRD positive. Now, the primary objective of this study was for all patients. And here you can see that the statistics show that there was not a clear benefit, one can say, although the p-value is 0.051. I was talking to Mark, there was actually 2 patients out of 350 could have shifted this way or that, and that could have made the difference. And in certain countries, like in the US, actually, the difference is huge. And certain countries like Europe, they actually saw very little benefit. So to me, I still think this study is the first study to show that use of the gilteritinib maintenance post-transplant can improve your survival. When you look at these curves, I think most of us as clinicians and patients want our patients to be on the top curve. You can go into details and long discussions on statistics, but I think that this overall is showing there's benefit. But leave that apart. I think the key message that comes out from this study is the use of MRD, because I actually think that this study probably, had we done it again, and Mark and others would have probably done the same, we would have probably just done an MRD intervention. Of course, in 2014, when the study was designed, we did not have 10 raised to minus 6 MRD. So this is always, hindsight can be 2020. But today, I think we do have the data that for those 50%, right, half of the study, big number, who were MRD positive, pre or post-transplant, absolutely gilteritinib improves your survival. Quite a big difference there in the survival. And those who are MRD negative, actually, you could say you may not need gilteritinib. One way to think about it is we cannot predict the fate of MRD for our patients, right? But if they're MRD negative, they have a good chance of doing well, 80% survival at 4 years. Okay. But if they're MRD positive, we have a good chance of bringing them to the same outcome as those who are MRD negative. To me, this is not a maintenance study. This is a MRD-directed intervention study, and MRD can be used to improve the outcomes of those who are MRD positive to the level of those who are lucky to become MRD negative. So the question then comes up is, well, what do we do today? Now, you're not going to have this assay. This assay, even in the US, is highly restricted. We're just setting it up in MD Anderson. Only 20% of academic centers have it. It was designed for this study, so it's all in the last 3 to 4 years. So what do we do if we don't have this assay? To me, I would say, look, you want your patient on this curve at any cost. The only thing you can do is you give them the maintenance until you have such an assay. And then either way, if the patient was MRD negative, you don't know because you don't have a 10 raised to minus 6 assay. Well, he's lucky. Yes, you gave him gilteritinib. There could be a little bit of toxicity. It's not a very toxic drug. You manage it. But for those other half or more who were MRD positive, but you couldn't tell because you don't have a 10 raised to minus 4, 5, 6 assay, you're still helping those. And in the end, the hope will be all your patients will be on this level curve. And so that's what our practice is even today until we set up this assay. But I think the study was very helpful to show that this is not that important. This part is not that important. The microclone business, I don't think it changes much. This part to me was quite important because I know in India, the technology is very, very good and it's moving quickly. And I'm sure you will have this kind of MRD 5 and 6 assay very soon. It's just technology, so it can be done. And the scientists and people who can do it are already there. So it'll come. What was really nice to show is that this really separates out. So, it's not just MRD positive negative. Every log level of MRD gives you a complete separation. I've never seen curves like this, even in ALL, where MRD 4, MRD 5, MRD 6, MRD 0, so below 6, you can see a complete separation. Now, remember, flow goes only to MRD 4. So if somebody tells me, hey, my patient is flow positive, I'm so happy, your patient could be here. You don't know. It could be here. It could be here. It could be here. You just don't know because you don't have the 5, 6, and no. So that flow is going to give you that best outcome somewhere in that 50 to 60%, but this could tell you all the way to 90%. Now, this was on placebo, right? On the quiz arm, on the GILT arm, everything moves up. So that's also nice to see. Every level, you see the GILT benefits it, although it gets a bit tricky once you get to a real MRD negative. So 10 raised to minus 6, I don't know if GILT is doing anything, but even at 10 raised to minus 4, this is the placebo, this is the GILT. At 10 raised to minus 5, this is the placebo, this is the GILT. These are big separations of 15 to 20%. So it really does show that if you have disease, and it's the more disease, then the GILT is going to do better. As your disease gets less and less, it's probably still going to be okay and help, and there's no harm, and the survival is still equal or better, but the use may be less. And maybe those are the people where you don't need 2 years, 6 months, a year. We don't know. But these are the things that we and others are thinking about and will be looked at in the future. The other thing that they showed is the kinetics of relapse. So this was a very interesting slide. So what they basically showed is that most of the action happens in that first 6 months post-transplant. So when somebody says, oh, I want to start maintenance, but I worried this and that, I'm going to do it 4 months, 5 months, you may have already lost the battle. This is where a lot of the activity is going to happen. So in that first 6 months is really where you start seeing either those people go to negative or they relapse, and placebo more relapse, less go to negative. So clearly showing the impact of that therapeutic intervention, except for some of these patients who, even after 6 to 12 months, you can see that they stabilize or they come down. So I don't think it says you should stop at 6 months, not yet. We're not comfortable with that, but you probably do want to start the maintenance earlier than later. Here they just showed that those patients who had multiple clones are the ones who could be the late relapses, and gilteritinib may or may not be as effective. I don't think that's so critical. So basically what they show is overall that use of gilteritinib based on MRD clearly can improve the MRD negative conversion rate, 69 versus 44% post-transplant. That's a big difference. Also, the first 6 months is a critical period. So the earlier you can safely start, of course, we have to look at GVHD and things, but the earlier you can safely start, if you can do it at day 70, push for that. Don't wait till day 90. If you can do it at day 80, do that. Don't do day 100. This study did it between 30 to 90 days. And then they also showed that any level of MRD appears to impact relapse-free survival clearly. Again, probably one of the first studies to show the difference between -4, -5, -6, negative, and that the better our MRD gets is kind of looking to the future. 10 years from now, when our MRD is super amazing, we're going to really be able to get to a point of predicting 95% survival versus 80, 90% relapse, very close to what our ALL friends are doing. It may not even take that long. It may be 4 or 5 years from now. So I think MRD is really here to stay. So I'm going to stop here. There were many other data sets that we presented more on the triplets and the novel HMA-VEN therapies, but I think those will be a good discussion for a future time. So let me stop and happy to take some questions. Thank you.
Thank you, Dr. Naval, for a fantastic lecture. And that was wonderful. And I request all of our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Naval Dever.
Don't feel shy. I know there's a lot of questions.
So,
Hi,
Dr.
sir.
Your question, please.
Yeah, sir. Good evening. So, thank you, Dr. Naval, for a very elaborate and a very comprehensive presentation about the molecular landscape of AML, sir. I have a few comments and some questions I want to get understand from expert like you. So, one is the problem with us is especially the population of elderly people. Is there a difference between the biological and the chronological age of our patients and your patients? Because you see that up to 70, 75, you give them high dose with a intensive induction as well as high dose RSC, but we're not able to give even to patients who are, if they are about 50, above 50. So not talk of above 60. That is one thing. So we usually end up with giving them Veneza, and most of them, even they don't tolerate venetoclax. Then we go with azacitidine only. So that is one. Can we see, besides the performance status and the general condition of the patient and the comorbidities, is there any parameter to look at the difference in the chronology and the biological age of our set of patients, especially the AML, very heterogeneous disease?
Well, I actually think I agree with you. Actually, I do think there's a difference in our patients and Indian patients, and even in our practice, we have patients from India and other regions, Middle East, very similar as well, who do not tolerate intensive chemo, and around 50, 55 is probably where we start considering them not suitable for intensive chemo as compared to 65 or 68 in the Caucasian white. The issue, of course, is that the trials are being run predominantly in Europe and US, now Asia, but even in Asia, it's really more Japan, South Korea have started being engaged, in China. So we're getting some of that data, but the data is predominantly was built on more Caucasian enrollment, 70, 80%, right? So we don't have an objective parameter as to what is the dose adjustment, the age cutoff, the performance status. Now, that being said, I think and that's why I showed initially that I think one does not have to feel the pressure to do high dose intensive chemo in their 55-year-old today as compared to 10 years ago, because 10 years ago, you look at AZA alone, 20-25% response, people get disappointed, patients get disappointed, physicians, and you say, I'm going to push the intensive chemo, even if there's a 15% mortality, I have to do that. Now, today you have aza-ven, and if you're lucky and there's a target, then you may have aza-ven FLT3. It could be mido, could be sorafenib, and your response rate is going to be exactly the same. Actually, I think it may end up being better because you will have less early mortality, colitis, infection. And if your path is eventually to take this person to some form of transplant, whether it's a reduced intensity or haplo, then let's do it with less intense approach, keep the patient preserved, organ function good, no major infection, no deconditioning, get them into that 80-90% remission and move to transplant. So I actually think this is a great opportunity. And when I was there last month, that's what I said, for India and other countries that are facing this problem to do such studies and say, look, we're going to take 40 to 60 years of age or whatever, 50 to 70 years of age. You pick a group and we're going to give them all HMA-VEN or HMA-VEN FLT3, and we're going to publish the outcomes in 40 years. And then we're going to overlap that on our retrospective control, or if one wanted to even do a randomized study of 50-50 patients and say, we're going to find out what is really tolerable and what the outcomes are. And that could then really establish what we are hypothesizing, that a low intensity, effective backbone, especially maybe with the targeted therapy, could be better than pushing intensive chemo. Yeah.
Thank you, Dr. Meet Hossain. Dr. Arinjan, your question, please.
Hello, Dr. Naval.
Hi.
Thank you for your elaborate discussion. So you talked about at length about the role of MRD in prognostication as well as probably treatment escalation. So my question is, in the current, the entire AML spectrum, whether it is the core binding AML, favorable risk AML, and as well as with regard to various therapies, consolidation cycles, transplant, as well as maintenance, is there any role of MRD in de-escalation or limiting the duration of maintenance? You did talk about that in diltertinib, probably the last Morpho study, it did tell that MRD negative were doing as well with or without giltertinib. Except that, is there any other scenario where you would use MRD negativity in de-escalating therapies?
Right. Yeah. So there was actually, I didn't have time, but actually there was one abstract looking at exactly that. This was from Othman in the UK. Jad Othman, last author is Nigel Russell. And what they looked at was using NPM1 and FLT3 based MRD, actually really NPM1 MRD, to identify which patients do not need transplant, basically. So they are trying to intensify therapy by avoiding allotransplant in patients, like is done in ALL. And what they showed was that there were two key issues with that study. One was that study was done pre-FLT3 inhibitor use. So with NPM1, 50% to 55% have a co-occurring FLT3, and today they would all get a FLT3 inhibitor with frontline. This study was 2013 to 18, so they did not get a FLT3 inhibitor. And the second issue was that they did not have a full genomic profile about the co-occurring mutations, DNMT3A, EZH, because we know these could impact the outcome in NPM1. But it's a big study, and basically what they showed is if you have an NPM1 mutated patient, regardless of if they're FLT3 positive or negative, after 2 cycles of intensive chemo, they do the DA. If they achieved MRD molecular negative, this is the whole problem. None of this is flow. These are using 10 raised to -5 or 10 raised to -6 molecular assay. There was no benefit to transplant versus non-transplant. What was really important was that 82% of the patients became 10 raised to -5 MRD negative. So the bulk of that population actually did not need a transplant. So if this were confirmed in the current era with FLT3 inhibitor use and other, which I think it will be, in fact, it may be even higher than MRD negative because you're adding a FLT3 inhibitor, it may be 85, 88%. It suggests that these patients, NPM1 mutated patients, for the large part, may not need transplant if you can document very high sensitive MRD negative. So that was probably the one study that said that you may avoid transplant. So yeah.
Thank you.
Any other question, Dr. Arikant?
Yeah.
Oh.
So this is with regard to the 821 scenario, and how do you use the uh, molecular MRD assays in guiding therapies, and particularly with respect to number of consolidation cycles, and also with respect to uh, putting them on a transplant arm.
Yeah, no, that's a great question. So yeah, we have used molecular. Gautam Borthekar in our group has published extensively on this for core binding for many years. Now, I think the key here, though, to start with, is that our approach to core binding is probably different from what's being done in India. So we have FLAG-GO as our backbone, and it's a very potent backbone. It is highly effective, and we basically see MRD molecular PCR clearance rates close to around 90%. Across all patients. So that's one of the key things. And this usually happens within the first 2 to 3 cycles. So for most of our patients with core binding factor, we do FLAG-GO, we achieve molecular PCR negative. We don't do transplant. We plan for 1 induction and about 4 consolidations. And we get GO usually 3 times during the course of their treatment. For those who are positive, what Gautam and our group showed is that those who are detectable above 0.1 after 3 cycles of intensive chemo with ideally GO are high risk. And so you have 2 options. You could either add anthracycline. We used to do anthracycline routinely. Today we have moved away from IDA-GO to just FLAG-GO for the core binding factor. So you could add back the anthracycline, and some of the people become MRD molecular PCR negative with that. The second option is you could add a maintenance, and we have started to do that, where we will do the 4 or 5 consolidations, and these people who are positive after 3 cycles on a PCR of 0.1 or more will say they are high risk and give them HMA or maybe HMA-VEN now for 6 to 12 months. The third option, which we have not really done as much, is you could consider transplant in such patients who remain molecular or PCR positive after 2 to 3 cycles. Usually, we have only considered transplant in those who have a MRD increasing. So let's say I did a end of cycle 2 and it's 0.14, and then at end of cycle 4 and it's down to 0.08, I would probably just do 1 more consolidation, then maintenance. But let's say it was 0.12 and then end of cycle 4 is 0.81 or 1.2, then probably we would say, okay, this is very risky, let's move to transplant. So we've usually reserved transplant in the setting of rising MRD clearly, and otherwise done a consolidation maintenance. Now that has to be considered in the Indian context, because for us, we have gemtuzumab. It's, oh, patients can stay for 5 to 6 months. Logistics and finances are more manageable. So one could say that in India, if a donor haplo transplant is not as expensive and gemtuzumab is not as available, that if you are PCR positive after 2 cycles, then it's a high risk. And unless you're going to be able to monitor and check and do 2, 3 consolidations and maintenance, let's just not take that risk and go to haplo. I think that's a very reasonable strategy. So, yeah.
Thank you.
Thank you, Dr. Thank you, Dr. Aryan. Dr. Niranjan Kher, your question, please.
Thank you, Dr. Dava. That was an excellent talk. You went through the journey in which molecular MRD has been developed, and it's quite clear that it's here to stay. One of the main questions I have is that the molecular markers for molecular MRD, FLT3, NPM, apart from that, I guess around 40 to 50% AML won't have a targetable mutation, in which we have to make do with flow. And that, I think, has to do with the biology of each mutation. It's very different. The chip mutations, they may not be markers of AML itself. So do you think there is anything in development for those AML, maybe some spliceosome mutations, maybe TP53 itself, that can eventually be used as a molecular MRD?
Yeah, I don't know. It's going to be tough. So yeah, they group at NIH, Chris Horrigan, they did look at this study. It's called the pre-measure study, where they looked at FLT3 ITD, FLT3 TKD, NPM1, and IDH1, IDH2. And what they basically showed was that, as we have shown, FLT3 ITD, TKD, NPM1 were good molecular MRD prognostic markers, but IDH1 and 2 actually had no prognostic value. So those became negative. and they had a 10 raised to minus 4 digital PCR, it didn't matter, negative, positive, the outcome was not different. So I think there are a lot of mutations in AML that may not be directly related to the leukemic clone. They may have been chip mutations pre-existing for many years and will stay for many years. And IDH is probably one of them, TET2, DNMT3A, ASXL1. So I think for that group, they probably will never be able to use as MRD markers, in my view. Flow or other technology could be the way to look at them. But then there are probably certain other ones, maybe TP53. So MLL, I will tell you that one, there is good molecular assay that is emerging, and we're working on that, and it does seem to be prognostic. So that's going to be the core binding. So we have core binding factor, FLT3, NPM1, MLL, for which I think you have good molecular markers which will become used. But for the others, either flow or there are technologies such as duplex sequencing that picks up all mutations and then tries to come up with a score based on the aggregate mutational clearance, and that may be another approach. So yeah, I think it's still a work in progress.
Okay, thank you. Another question, if I may. I was very interested in looking at the data of the BMT-CTN study you showed, and we are eagerly looking forward to read through it. One of the small things in small print I noticed was they're setting the first 2 ml for MRD, which I
Yes.
think makes a lot of difference, the technical aspect of it. So on lines with that, we see a lot of patients who received aza-ven have prolonged cytopenias, and the marrow quality is usually inadequate even to label it as MLFS. So
Yeah.
is such patients with aza-ven, very poor cellularity, has a molecular MRD been validated for such patients also, or probably that's not of any diagnostic value if the marrow is very hypocellular?
Well, it has not been done, to my knowledge, on HMA-based therapies. The high in vivo scribe molecular assay, we're actually working on it right now. We just had a couple of meetings with our molecular, so there will be data hopefully in the near future on. Actually, no, we did it. So the HMA-ven gilteritinib, the paper that's in JCO, if you look at it, Nick Short is the first author. I'm the second. You can see we had patients, a small group, where we did the 10 raised to minus 6 molecular assay, and it did seem to track very nicely with survival. So this was on the setting of aza-ven gil, but I don't recall if these were the first end of cycle 1 marrow or later marrows, because with HMA-ven, you're right, it's the first marrow is usually highly hypocellular and insufficient, but as you adjust and give time and reduce the ven, you do see by end of cycle 3 or 4 good count recovery and more cellular marrow. So it could have been that, but yeah, I think it can be done. It just may not be at that first marrow. It may have to be later.
Okay, thank you.
Thank you, Dr. Niranjan. Dr. Alka, your question, please.
Hello, Dr. Dawar. It was very nice to hear your talk, and very interesting to know about the maintenance therapy post allo transplant in AML patient. So my couple of queries, like regarding use of molecular techniques for using FLT3 ITD for as a marker for MRD, because I read in literature that it is a quite unstable gene also. So where it may be negative, but patient may still be having MRD positivity. So how do you, take that into account? And the other question is about use of maintenance therapy post-transplant, starting from day plus 30, as you have mentioned in one of the trial. So it was very interesting for me to know. And as it was shown that it is the initial 6 months which are very crucial for any relapse. So I just want to clarify that those patients who were MRD negative before transplant, so even those patients also got gilteritinib as a maintenance therapy, and that too from day plus 30, or if they were being monitored and once the MRD started becoming positive, then it was started, or irrespective of MRD status, before transplant, everybody received gilteritinib from day 30 onwards. These are
No, good question. So the first one about, the FLT3 being one of the later hits, not potentially being a pervasive marker and seeing FLT3 negative relapses. biologically, that's what a lot of people thought and said. But when you look at the survival data, whether it's with the quizartinib intensive chemo or the gilteritinib, I mean, FLT3 is standing out as a pretty good MRD marker. Now, it doesn't mean it's going to capture all patients. So I still think it can give you a difference between survival outcome, and it's still usable, especially for adding the intervention like gilteritinib. If you have the marker, then that's the only time you really want to add the target. Otherwise, it may not be. But there will be, in that part of the Morpho study still being analyzed, as to the patterns of relapse, how many patients relapse FLT3 negative. And that it may be the reason we want to do both. So at Anderson, we will be doing both flow and molecular, because the molecular will capture the 60-70% who have a persistent FLT3 and then can get gilteritinib targeted therapies, and then the flow may capture the other clonal escapes that may be FLT3 negative. So I do think we need to look at both, and that data will be coming from the Morpho study as well. Now, the second part is this was all post hoc. So the Morpho study did not have real-time PCR for decision making. The study was basically enrolling all patients who had a FLT3 mutation who went to transplant, and then they were randomized to get either gilteritinib or not. And that was the primary endpoint. However, at the end of the study, the samples were all analyzed, and then the molecular data came back. But in the future, that could be a good study design to look at patients prospectively pre-transplant. If they're molecular negative, and then post-transplant they're molecular negative, maybe you do not need to give them gilteritinib. But this all has to be done with the very high sensitive 10⁻⁻⁶ molecular assay, not with the current 10⁻⁻² or 3. Now, the day 30 is the lower end of the spectrum. So it says day 30 to 90. The median time was around day 60 to 70 when people started maintenance. It's very difficult, as you're alluding to, to really start on day 30. So majority were starting closer to day 60 to 80, which I think is fine.
So another question, if I may ask, for how long we should continue with the maintenance? Like,
Well, yeah, I mean, the study, I would just do it the way the study was done for now. It was 2 years. So that's kind of what we are doing. There's very little data to show that shorter or longer would be better. So, I mean, that's kind of the, recommendation today is 2 years.
So during the maintenance, you must be measuring MRD frequently. So at what time points you are measuring?
So we're doing 3 months, 6 months, 1 year, and then basically 6 months after that. So 3, 6, 12, 18, and 24. Yeah. So 6 months matters pretty much. Yeah.
Thank you so much. Thank you so much.
Sure. Okay, well, I'm going to have to go. I have to take my son to a baseball game soon. So, yeah.
So fine, because we had some questions from the audience. Anyways, no problem, sir.
Email them over if you don't mind, Dr.
Sure.
Khurana.
No problem. No problem. Thank you so much, sir, for that wonderful lecture. And what a lovely discussion, sir. Thank you
was
for
great.
getting your time
Great to
this
see you.
Saturday for us, sir. Thank
Great
you.
to see you all. Thank you. Have a good evening. Bye.
Thanks a lot.